So good evening. My name's Dr. Sunil Narayan. I'm a board certified vascular and interventional radiologist with IR Centers. I'll just wait a couple minutes here for people to join. This presentation is being recorded, so if you missed some of it, that's fine. We'll share a link with you at the end so you can rewatch it if you miss a point or you want to go back and review. And the presentation part of this will probably take about 20 minutes, 20, 30 minutes, and then we'll save some time at the end for questions. So if you have specific questions, feel free to enter them in the Q&A, and I'll do my best to answer those. If they're specific to your personal situation, that's may be best reserved for a consultation, but feel free to put them in, and we'll do our best to get around to those. All right, so it's 7 p.m. Central or 8 now, so we'll go ahead and start. So again, my name's Sunil Narayan. I'm a board certified vascular interventional radiologist with IR Centers. IR Centers, for those of you who don't know, is a national practice. We have about 30 centers across the country and over 40 docs um, that specialize in minimally invasive healthcare in the outpatient setting. So today we're going to talk about uterine fibroids and some of the minimally invasive treatment options that are available. Um, so what does that sound like, or what does that look like for the patient with fibroids? So the most common thing patients encounter is heavy bleeding or heavy periods. So the technical term for that is menorrhagia. So, bleeding during your period that's soaking through pads or tampons every hour, having to change them, uh, multiple times a day, bleeding that lasts longer than 7 days. Um, you can also have bleeding in between periods, um, passing large blood clots. This can be associated with other medical conditions like anemia, which is frequently an issue that comes up in routine preventative care. The screening and will identify it. Some patients even have to get blood transfusions or iron supplementation for their bleeding. Um, and that can manifest in a number of symptoms like fatigue, low energy. It can affect people's work and their lifestyle. So those are the bleeding symptoms. There are also what we would call bulk symptoms that are related just to the mass of fibroids. So, what they can push on. So, pressure, fullness, bloating, abdominal swelling, back pain, pelvic pain, even leg pain. If they're, exerting mass effect or pushing on other organs like your bladder or bowel, they can have symptoms related to that. So there's a kind of a whole constellation of ways that this can present. And it really sometimes is tough to figure out if it goes on for a long time. And that's kind of the role of consultation. Um, so this is kind of just to give you an idea of how this may present in your life because it's often the fibroids are essentially tumors. They're benign, but they're benign meaning not dangerous in the way that we think of cancers, but they're tumors of smooth muscle that can grow under the effect of hormones. And so they can fluctuate with your cycle, and so that can present throughout the course of the month, and it may involve missing days from work, having to interrupt your life or your work because of the bleeding. Obviously there's a financial cost associated with that, particularly if you have anemia or fatigue associated with the bleeding. Um, and this can prevent in a number of other ways that can affect your family and your lifestyle. So we kind of alluded to this a little bit already. So what are fibroids? They're not cancerous growths. The technical term is uterine leiomyomas. So it's a tumor of smooth muscle. Um, and it's not dangerous in the sense that we usually think of, like of colon cancer or lung cancer, but they can grow under the influence of hormones, and because of their size, they can either bleed or, as we said earlier, exert mass effect. and that can result in significant impairment. They're fairly common. They affect a large number of women, almost 80% of women by the time they reach the age of 50. They can range in size from, from a pea to a grapefruit to soccer balls. Um, and depending on their size and their location, that kind of determines what symptoms they can cause. And so, not every woman who has fibroids will be symptomatic. So that's an important distinction. If you have an imaging study that says you have fibroids, that's not in and of itself something you need to worry about, but it does kind of, call into mind, you have to be mindful of okay, yes, I have been experiencing some symptoms of bloating or abdominal swelling. And if it's sometimes hard to piece together, that's why we exist to help you out and determine if, what you have on imaging or incidentally have found could be what's causing your symptoms. Important to know this is never your fault. These are things that can be naturally occurring. And as we said, even people without symptoms can have them. There are some predisposing factors in terms of ethnicity and family history that can predispose people to having these. Um, but there are a number of treatment options available to you for them, so we'll kind of go into those a little bit more. They're not all created the same. So there are four kind of different classifications of fibroids depending on their location in the uterus. And that kind of determines what symptoms they cause. So in the top left, the submucosal ones are the ones that are most commonly associated with bleeding symptoms. So submucosal means they're basically underneath the inner lining of the uterus. And because of that location, they can rupture and kind of bleed into the uterine cavity and be associated with the typical heavy bleeding, the passage of clots, passage of tissue, and the like. Um, Intramural fibroids are fibroids that are actually within the muscular wall of the uterus, and they can cause both bleeding symptoms or bulk symptoms. Um, so somebody in the Q&A actually asked a question about postmenopausal bleeding. I'll get to that a little bit later. Postmenopausal bleeding is a specific circumstance that really needs to be evaluated in consultation with an OB/GYN. And the reason for that is postmenopausal bleeding specifically you need to rule out other etiologies like endometrial cancer. So, we try to work in collaboration with your OB/GYN, and it really depends on your age, when these symptoms are becoming an issue. So if you've had bleeding all your life versus if you haven't really had symptoms and then after menopause you start to have symptoms. So the typical natural history of fibroids is that usually during the fertile years of your life before 50, you'll typically have symptoms. So it would be unusual for a woman to begin to have symptoms after menopause. Usually the symptoms start to recede or get better after menopause. When they don't, that kind of raises the concern for other etiologies that we have to evaluate for. And we can kind of go back into that a little bit. Um, Subserosal fibroids are fibroids that are kind of on the outer wall of the uterus. Uh, and the uterus itself is in the abdominal cavity. So it can if you have masses there, it can push on other things, specifically bladder, bowel, other organs. And because of that, can cause specific symptoms like constipation, urinary frequency, dysuria type symptoms, even back pain. And that's where the imaging really helps, whether it's ultrasound or MRI, because depending on what kind of fibroids you have and where they're located, it may help to explain the symptoms that you're having, um, and specifically counsel you on how well those will resolve and if there's any specific issues associated with treatment you need to be aware of. The pedunculated fibroids are really referred to when the fibroid is attached to the uterus by a stalk. Sometimes if that stalk twists, you can have pain related to ischemia. And sometimes if you treat those, if they can, possibly fall off and cause symptoms. So that's a specific situation patients need to be counseled on. Um, so we alluded to this a little bit, which cause the most bleeding. So it's typically the submucosal fibroids. And that's why the imaging helps, to kind of get an answer as one of our patients asked about the postmenopausal bleeding. So, if you're having symptoms that aren't really explained by the location of your fibroids, then it kind of, gives us a clue that we need to look into other answers. So why do fibroids cause problems? So, fibroids disrupt the body through kind of two distinct pathways that we already talked to a little bit, the bleeding pathway and the bulk or pressure pathway. Both pathways are treatable with uterine artery embolization, but the time frame the symptoms will resolve on and the specific natural history may differ slightly. So typically the submucosal or intramural fibroids in the lining or muscle of the uterus are more likely to cause bleeding symptoms, whereas the larger fibroids, which can be either subserosal, intramural, or pedunculated, are more likely to cause the bulk symptoms by pushing on either the bladder, rectum, bowel, or nerves. And really, for the bulk symptoms, you want to shrink the fibroids. And that outcome generally takes about 3 to 6 months after an embolization to get the desired result because you're cutting off the blood supply and really relying on the body's response to cutting off that blood supply to shrink down the fibroids from their original size. Whereas the bleeding, uh, when you're treating abnormal blood vessels within these fibroids, will resolve more quickly. You will continue to notice some improvement over time, but the time frame for those two things differs a little bit. So just to put this all in the context of a typical patient, someone I've met and spoken with before, we'll talk about Sarah. Sarah's a 42. She's a project manager. She's a mother of two. She spent years kind of either pushing through or ignoring her symptoms, like many women. Was told she has, bad periods. Um, she often will soak through pads or tampons at work. She, will be told by her primary care provider she has anemia, either nutritional or iron deficiency. In this case, it might be related to blood loss. Um, because of the fatigue associated with that, she often has to modify her work schedule. She may miss meetings. She may have to seek additional treatment for blood transfusions or iron supplementation. She may have seen an OBGYN in the past and told that hysterectomy was her only option. And so this is a very typical story. And the main thing I want to leave you with is that there's a number of different options for treating these, of which hysterectomy is one, uterine artery embolization or uterine fibroid embolization is another, and then even myomectomy is another. And I think the specific correct treatment option really depends on the person and what their symptoms are, where their fibroids are, and what they're hoping to accomplish, and what their plans are, for life, including, family planning and things like that. And that's something we can help you figure out. So, what are your treatment options? Um, so uterine artery embolization is one that specifically we offer at IR centers that we've done hundreds of here. Um, the other options, which are generally surgical, are hysterectomy and myomectomy. And the main difference with uterine artery or uterine fibroid embolization is that's a uterus preserving or sparing procedure, meaning that when we're done with the procedure, you're still going to have a uterus. Whereas with hysterectomy, the uterus is removed. It's generally done under anesthesia. There's a hospital stay involved, usually 2 to 3 days, and the recovery time is usually significantly longer. Um, but when you're done, you're not going to have a uterus, and by extension, you can't have problems with things in the uterus like fibroids. And so, if you'd really just rather get the uterus removed, then that's probably the option for you. If you're someone else who doesn't want to have an organ removed, then the options kind of are between surgical and non-surgical, of which the myomectomy is one option where myo meaning muscle removal. So They're literally removing fibroids. Which fibroids they're able to remove and where, really depends on your consultation with a gynecologic surgeon, and whether they're able to remove them all or just specific ones. Um, Still a hospital oriented procedure requiring anesthesia, usually a little bit shorter recovery time than the hysterectomy, but not quite as short as the uterine artery embolization. The uterine fibroid embolization is generally done in the outpatient setting. You can do them in the hospital, but it's generally safe to do as an outpatient procedure and discharge the same day. Recovery time, I would say, is usually 7 to 10 days, in terms of your body's response to the embolization. So, embolization, we cut off the blood supply to these fibroids or tumors, and in many cases, infarct the tissue, meaning cut off the supply of oxygen. And by doing that, the fibroids will die and shrink, and thus reduce the bleeding problems they present and bulk symptoms they present. There's no big incision with the embolization. It's made through a needle puncture at the top of the right leg or through the wrist. And when you're done, you'll just have a gauze and a tegaderm that can come off in the shower the next day. All the fibroids in the uterus will be treated, which is, a slight distinction from the myomectomy. Um, and then usually the follow-up is, with the performance provider. So in our case, we follow up with you 1 and 3 months, and then see how you're doing from there. Observation and medication are obviously, things that you can do in conjunction with either your OBGYN or primary care provider, um, to varying success. So why might women choose a uterine fibroid embolization? So, the main distinction obviously is preserves your uterus. So if you're not ready for a big surgery or you don't want to have your uterus removed, this is obviously, a great option for that. Um, People who are unsure about their future plans to have children, obviously if you may want to have children in the future, then it's behooves you to preserve your uterus. So this is probably a better option. It's a smaller incision and by extension, shorter recovery time. Um, you know, Usually the bulk of the symptoms, which can encompass mostly pain, nausea, low-grade fevers, fatigue or malaise, usually last about 5 to 7 days and probably 7 to 10 days at the most. Generally managed with medication, outpatient medication, and usually you're able to, get back to normal activities and work, after a week. Um, there's no major surgery. You don't need anesthesia or intubation for this procedure. So, conscious or moderate sedation is usually sufficient to do the procedure in the outpatient setting. Procedure takes probably between 30 minutes to an hour and a half. The average procedure time is just under an hour. After the procedure, you lie flat for 30 minutes to an hour, and then you can go home same day. Because of sedation medications and the access to the blood vessel, usually you'll need somebody to drive you home the day of the procedure. But you should be kind of back to your normal self by dinner time, with the exception of those symptoms I mentioned earlier. Um, Lot of evidence for this procedure. So, it's a procedure that's somewhere between 80 to 98% effective at treating bleeding and bulk symptoms related to fibroids in the uterus. There's uh, hundreds of articles kind of detailing its effectiveness. So it's generally a very safe procedure. So what happens specifically during the procedure? So, assuming you've had the consultation on your procedure day, you'd come into our office. We get you changed into a gown. We typically give some form of sedation, so we get an IV access to give you fluids and IV medication for sedation. We do occasionally also give oral medication while you're in the recovery area, just to make you sleepy. You should be comfortable the entire time of the procedure. The procedure itself is painless. When we get you on the table, we give some numbing medication in the skin just above where we access the blood vessel, either in the wrist or the groin. Once it's numb, we get our access like an IV into the vessel. And then under X-ray, we guide a catheter into the blood vessels that supply the uterus. And then we inject material, which is typically microspheres, into the blood supply to the fibroids. And we treat the entirety of the uterus and all the fibroids in it. The particles we use are of a size that's chosen specifically to address the perifibroid arterial plexus, so which is typically between 500 and 1,000 micrometers. Um, so it's essentially procedures designed to specifically address the fibroids, but the entirety of the uterus is treated and all the fibroids in it. The normal uterine mucosa should recover within 48 to 72 hours, and the fibroids should shrink and the bleeding should get better. The full benefit, we follow up with patients around a month, and you may start to notice some improvement at that point. The full benefit probably takes 3 to 6 months to get, particularly for bulk symptoms. So what's actually happening? We alluded this a little bit, but we're using the X-ray to guide a tiny catheter inside the blood vessels, specifically into the blood vessels that supply the uterus. And by choosing the size of the microspheres, we're essentially addressing specifically the blood supply to the fibroids and essentially cutting off the supply of oxygen and nutrients so that the fibroids shrink. They will typically reduce in size 40 to 60% uh, over that time frame I mentioned, around 3 to 6 months. The size change doesn't always correlate with the symptom improvement. So when we follow up with you, we try to focus on the symptoms and figure out if the symptoms are getting better. If your symptoms are not getting better, or if some are and some aren't, then the imaging may help in kind of troubleshooting if if there has been enough reduction in size of fibroids to address your symptoms. Um, so the healthy uterus stays healthy. So as I mentioned, there may be initially some shock to normal uterus, but should recover within 48 to 72 hours. The infarction and shrinkage should happen in the fibroids more so than normal uterus. Um, there are a lot of collateral blood supplies to the uterus and also the ovaries. Um, but generally we don't target the ovaries. But the goal is really to shrink and infarct and shrink the fibroids by cutting off the supply of oxygen and nutrients. Um, and as I mentioned, usually around 3 to 6 months is when patients get the full benefit. Um, so just an example, a patient has an MRI showing the diagnosis of fibroids. In consultation, we make a decision that fibroids are likely cause of patient's symptoms such as bleeding or bulk symptoms. Um, we'll do the treatment. Treatment lasts a day. We'll provide medication to get you through that initially recover period, which is around 5 to 7 days. We'll follow up with you after a week, and then again at a month. Just make sure you're on your way to a good recovery. And then usually between 3 and 6 months, we'll follow up with you, usually by phone. We can also do in the office and just make sure your symptoms are improving. If there's any question, we can repeat imaging and kind of get a sense of how things are going. Usually about 12 months later, the symptoms that you should initially presented to us with, whether they're bleeding or bulk symptoms, should be well on their way to resolving. And you should be kind of back to, a better life without those bleeding or bulk symptoms. And kind of avoiding hospital stays, bills, and the risks and complications that you may encounter in that scenario. So just to kind of break down the recovery, I alluded this a little bit, but when I talk with patients in consultation, I always try to really spell out what they're going to experience after the procedure. It's not a surgery, but we are doing something to the uterus and the fibroids, and by extension, you will feel the results of that. So the recovery is real, and the symptoms are something called a post-embolization syndrome, which is a constellation of symptoms that you can expect within the first 5 to 7 days after the procedure. That typically encompasses cramping or pain, fatigue or malaise, just generally not wanting to do, what normal activity is. Low-grade fevers up to 99, 100 are possible. And some patients have nausea. We provide medications to help with all those symptoms, generally worse in the first 24 to 72 hours and getting better over the course of about a week, but can last up to a week. Usually after a week, you'll start to kind of transition back to normal energy levels, feeling more like yourself and ready to get back to work. Um, because of the arterial access that we use for this procedure, we recommend patients abstain from heavy lifting or strenuous activity for about a week. And that's separate from the uterus. That's just to prevent any bruising around the access site. So generally speaking, walking is okay, going upstairs is okay. Lifting 15 to 20 pounds is okay, but anything more than that, we tell patients to give it about a week. Week two, generally okay to return to work and normal activities of daily living. Symptoms should continue to improve. Some pain or cramping occasionally is possible. Some spotting of blood is possible. Between 1 to 3 months, the fibroids will be actively shrinking. Bleeding should be starting to decrease. Pressure and some of the symptoms should be improving. And usually around 6 months would be kind of the peak benefits that you'll get. Um, so, like I said, this is a procedure that's been done across the country. There are hundreds of papers on it, done both in the outpatient and hospital setting. Over 95% patient satisfaction, over close to 98% improvement in bleeding, around 90% bulk symptom relief, which really can be discussed in consultation, depending on what kind of fibroids you have, where they are, what kind of symptoms you're having, and whether the fibroids themselves are specifically responsible or if there are other factors. Um, Procedure's been around for over 25 years, and thousands of women have been treated with great efficacy. Uh, Someone in the Q&A, I think, did mention, is it possible to carry a pregnancy after a procedure like this? It is possible to carry a pregnancy after a procedure like this. So it's important to outline this is not a reliable form of contraception. There are numerous instances of patients having uterine artery, uterine fibroid embolization, and then having and carrying pregnancies to term after the fact. So it is possible. Um, the data about this is not 100% conclusive, but there is some data to suggest that if you are definitely wanting to have children or become pregnant in the future, then a myomectomy may be a better option for you to specifically preserve fertility. The uterine artery embolization treats the entirety of the uterus, and there's some suggestion that the overall fertile capacity may decrease, so that if you definitely want to have children, we don't want to necessarily reduce your ability to do so. Um, so if you're pretty much 100% convinced that you want to have children in the future, usually we would recommend patients to at least consider a myomectomy, just to preserve as much fertility as you can. Okay, so understanding risks, what to expect, and when to call us. So normal recovery, pelvic cramping pain, which can start, by the end of the procedure, and lasting for up to 5 to 7 days after the procedure is common. And typically that's the body's response to cutting off the blood supply, oxygen, and nutrients to these muscular tumors. Low-grade fevers up to 99, 100, usually in the first 48 to 72 hours, but can be up to 5 to 7 days after the procedure. Typically addressed with Tylenol or NSAIDs. Um, Fatigue, mild nausea, very possible. Again, your body's response to the treatment usually doesn't last more than a week, and we do provide medication for these. Vaginal discharge is possible, and this is, I think, the importance of the imaging and the consultation. So if on the imaging we notice specifically, very large or pedunculated submucosal fibroids, we can specifically counsel you on that. That being said, circumstances where this would require an additional procedure or further intervention are pretty rare. But the imaging would help us to counsel you better on whether that's a possibility or something we really even need to entertain. In theory, it is possible. Heavier periods with first cycle after you feed, this is very possible, and I've discussed this with a couple patients. So if after a month after the procedure, I've had patients who are like, oh, I'm not cramping or bleeding anymore. I'm sorry, I'm not cramping or having as much pain, but my bleeding is as bad as it was. That can happen. And like I said, it usually takes about 3 months to get the full benefit because you still may have some degradation of submucosal fibroids or abnormal tissue in your first cycle after treatment. Um, when to call us, things that we wouldn't classify as low-grade fevers over 101 after day 3 or certainly after the first week. Pain that's not responding to prescribed medication we send you, new symptoms that were previously things you never had, specifically, unusual or foul-smelling vaginal bleeding or discharge. Difficulty urinating, so you should be able to urinate, and generally we check for patients to be able to urinate before they're discharged. Because of position of fibroids that can push on the bladder or the effects of sedation, we want to make sure you're not having those issues. So definitely let us know if you have a long period where you're not able to urinate, anything that feels off. High fever, shakes, chills, pain. These are things that you should call us immediately, and possibly we may have to send you to the hospital for, but exceedingly rare. Um, so why IR centers? So, as I mentioned, we're across the country. We have over 40 docs. We have the ability to webcast our cases to over 40, board certified uh, vascular interventional radiologists in real time to get second opinions within seconds, which is something that's unique to our practice. And by extension, we have access to thousands of hours of experience from a number of doctors. So you may consult with myself or another physician, but you get the benefit of you know over 40 doctors experience. The outpatient model is one of the cheapest, fastest, most efficient ways to get your care. I give all my patients my cell phone after hours. I'd much rather have you call me and talk it over than show up and sit in an emergency room. We can find a solution to most problems within 5-10 minutes. Um, if you need to see somebody, I'll have you come in within the next day or within a week, and we can talk it over if you're having issues. So I think it's just an unparalleled level of expertise, access, and experience that you have access to when you work with us. And I'd love to be able to help you with whatever your issues are, even if it doesn't involve a procedure from us. I'm sure I can help guide you to the correct place for you to get your care. Um, so just some testimonials of women that we've treated. Um, we try to have a fully patient-centered experience from our techs and nurses and physicians. Everyone will treat you as a person and make sure that all your concerns are addressed before you go on the procedure. You have a chance to voice any concerns, and as I mentioned, you'll have phone access to myself or whichever provider is taking care of you in a way in my experience, was not available in the hospital, which is part of why I chose to deliver care in this method. Um, so some of the things we already kind of talked about, just to summarize, hysterectomy versus urinary embolization, hospital-based procedure versus outpatient stay, go home same day, recovery within 1 to 2 weeks, tiny incision, no big scars, possibility of future pregnancy, all your fibroids will be treated, very low risk of complications, and no real chance of permanent or long-standing surgical complications. Hysterectomy, obviously, you'll have a much bigger incision. Um, Uterus is not preserved, is removed. So if that's, a desire of yours or important to you, maybe a better option, but also greater risks and recovery encompassed with that. And sometimes that's the right decision, and we can kind of help you towards that if that's what's right for you. Um, so to get a better look at what's going to happen in your consultation with us, so we can do it either over the phone or in person. Um, if there's any doubt, in person is always great. We will review your history, get an idea of, how long you've been having symptoms for, what workup has already been done. We'll review your imaging. If we don't have it on hand, we'll figure out a way to get it. If you need new imaging, we can always order that and review it together. Um, and we'll kind of piece together how your imaging fits with your symptoms and make sure that we're getting to the right answer. We'll go over all the treatment options and make sure that whatever treatment option we go with is the best choice for you. And we'll make sure all your questions are answered and go from there. And then typically we can schedule you if you want a procedure with us. We can schedule you often um, for a procedure. The waiting times vary, but usually we can tell you what's available the same day, or we can have someone call you back. The insurance end of things we'll look into for you and let you know before you come in, so you have an idea of costs. It's not a surprise, basically. Whether it's right for you, again, we've talked about this in the presentation. It's really dependent on what symptoms you're having, what your imaging looks like, and a consultation with your doctor. Um, really piecing together how the imaging and your symptoms fit together, and we can kind of help you figure that out and figure out what the best procedure for you is. This is a wonderful procedure. I think it's an outpatient procedure. It'll get you home the same day. It'll get you back to your life, your work, your family, your responsibilities much faster, I think, than surgery at a lower cost, and much less disruption to your life. So I think it's a great option, assuming it fits for you. So how can you get a hold of us? So best way is, we have a website, ircenters.com, that will kind of outline all our centers across the country. You can see which one's closest to you. You can see the docs at each center and who might be available to consult with you. You can get their kind of bio and see, who you think you might get along with best. You can call the centers and set up an appointment that way. If you have questions, we have a kind of portal on our website where you can submit questions or requests for consultation that will get filtered to our docs at each center, and they'll get back to you by email. So we're always available that way as well. Okay, so that's the presentation. So I think we addressed a couple of the questions. We still covered about a little bit longer than I anticipated, but we can go to some of the questions we answered already. There was one here. What is the risk for calcification of the fibroids? Are there other potential negative outcomes to consider? Okay, so the calcification part in and of itself is not a big concern. There are different types of calcification. There's um, dystrophic calcification and essentially calcification of dead or necrotic tissue that can happen, but in and of itself is not a big concern, just the calcification by itself. I think the other outcomes you're probably referring to are things, the goal of the treatment, uterine artery embolization, is essentially to cause infarction or uh, necrosis of the fibroids to get them to shrink. Depending on the location of the fibroids, that may cause different issues. Typically, in the vast majority of the times, your body's own immune system, when there's dead tissue, will be, essentially sterile. And immune cells in your body, called macrophages, will ingest necrotic tissue, and that whole area will shrink down. Depending on the location of the fibroid, there's always a chance that you can have, the part of the reason we talked about the stalks or pedunculated fibroids is, let's say, for instance, you have a submucosal fibroid in the uterus that has a stalk. There's a chance that the stalk can necrose and the fibroid itself can come off inside the uterine cavity. This is something that people have talked about a lot. It tends to be exceedingly rare. Um, if that were to happen, usually you would have some clue that that was a risk beforehand. So on the imaging, either MRI or ultrasound would show that the location of the fibroids, if there was a a pedicle, and then we could counsel you on that. In that context where you have a fibroid within the uterine cavity, sometimes you would need to get a hysteroscopy and get the fibroid removed. Sometimes, if it's smaller, the patients can pass that tissue on their own in the form of kind of like a clot or degraded tissue. And sometimes that can be associated with, cramping pain as you pass the tissue. There's some risk of infection associated with that. Typically, we'll give patients antibiotics in the immediate post-procedural period to cover for things like that. Um, but, it really comes back to the consultation. So, a diligent review of the imaging should allow us to specifically counsel you on whether that's even an issue. It's hard to say. It's something that needs to be discussed for most patients because they may not have that specific anatomic issue. Um, Even in patients who do have, pedunculated either submucosal or subserosal fibroids, although there are case reports of, fibroids either becoming detached in the uterine cavity or in the abdominal cavity, the incidence of this is pretty rare. Um, And the imaging would tell you that it's a possibility that would kind of give you a heads up if there were any issues like fevers or something that may think you that's a possibility. But it's an important question. I'll give a few minutes for some other questions, and then we can wrap this up. Let's see. I think somebody was asking a question about uh, fibroids after menopause. I think it's worth a consultation. It kind of depends on your symptoms. It's unusual, as I mentioned, fibroids usually grow under the hormonal influence of premenopause. So, the normal menstrual cycle will cause them to grow. It's unusual to have symptoms after menopause that are specifically related to fibroids. So it often raises concern. If cancer has been ruled out, it really kind of begs the question of, what the symptoms are. Are they bleeding or are they bulk symptoms? There are other etiologies that can cause bleeding even apart from cancer. Um, that embolization probably wouldn't be the answer for. Um, but the kind of intricacies of that really are probably better for a consultation. So usually, we would figure out what your symptoms are, And we probably have to look at the imaging and try and figure out what's going on. If it's pain, like pelvic pain, there are other etiologies that are even vascular etiologies that may be contributing that I would probably want to rule out. Um, but it's worth a discussion. Okay, well, I think that covers all the questions we had. Um, we will send out a link to this presentation to everyone who registered. So if people missed it or there's something that they wanted to review, you'll have that available to you. Our contact information is in there if you want to reach out to us to schedule a consultation. We're always happy to hear from you. Thank you again for registering. Again, it's Women's Health Fibroid Awareness Month, so we appreciate your feedback and your attendance, and I hope this was helpful to everyone. And again, if there's any questions, don't hesitate to reach out to us. Oh, I think we got one more question. Are there any preventative measures you can take now to shrink the fibroids? Um, the short answer is not really. Um, at least in terms of preventative measures. There are some conservative treatments you can consider in terms of hormonal things that you can discuss with either your primary care or your OBGYN. Um, but again, almost 80% of women have fibroids before age 50, so they're exceedingly common, not really able to be prevented. So the short answer is not really. Um, the recording will definitely be made available. Well, anybody who registered will send out a link, and you can review the whole thing. And then again, our consultation information will be available in there, and just feel free to reach out to us. Again, thank you so much for joining us, and look forward to hearing from you. Good night.